Morning, everyone, and thank you so much, Carlene, for that really warm introduction. I'm truly honored to have been asked to speak to you today. I especially want to thank Carlene and the Massachusetts Public Health Association for all that you do to catalyze change, to advance health equity, and to promote health and wellness throughout Massachusetts. So I'm going to talk about a challenging topic, but I do want to both begin and end with a message of hope. So as a country, we have been confounded by persistent and pervasive population level racial health inequity for a long time. And amid the racial inequities that were amplified by COVID-19 and the very tragic and very public murders of Black people, including Mr. George Floyd, these terms, health equity, racial justice, and structural racism, really became quite popular. And many people, maybe even myself, have talked about a racial reckoning regarding health inequity occurring in our country. And I think that there was a sense that with greater awareness, greater interest, progress was on the horizon, and that a better, brighter, and more equitable day was ahead in terms of health equity in this country. So, as I said, I was going to begin with some hope. I think some progress has been made, but for so many, so little has changed. And most of us, including myself, are still waiting for that racial reckoning to truly begin. But I do have hope, and so do you, or you wouldn't be here. So let's talk about why racial health inequity persists and what we aren't doing about it yet. I'm going to start by reviewing data which demonstrates persistent inequities in health outcomes in Boston. And of note, Boston's not an outlier. These are data that we see across the country. Then I will describe a few current strategies to advance health equity with a focus on what we're doing at the Boston Public Health Commission in partnership with hospitals, community health centers, and community-based organizations. And like I said, it's a partnership. So there are a lot of people doing a lot of things across Boston. And last, but certainly not least, I really want to turn to and spend some time on the takeaway message here. And that is that we need to identify and pursue opportunities for change and to think about what we need to do differently at this point to really move the needle going forward. So let's start with life expectancy. Life expectancy is one of the most highly cited measures used to assess and compare health equity across cities, across counties, across states at the country level. And as is the case in most cities, there are significant and long-standing disparities in life expectancy in Boston by both place and by race. So you may have seen these data. I'm hoping that most of you, those of you who are from Massachusetts, have seen these data. Back in 2012, a report was released that found that life expectancy in Boston varied by as much as 33 years between a census tract located in Back Bay and a census tract located in Roxbury. Now, these census tracts are about 2 miles from each other. And so in Roxbury, average life expectancy was 59 years, and in Back Bay, it was 92 years. So these data were from 5 years spanning 2003 to 2007. So essentially they're 15 to 20 years old. And the question really is, where are we now? Has life expectancy in Boston improved over time? Have we made progress? So let's start with citywide life expectancy. So in Boston, life expectancy is a little over 80 years of age, which is higher than life expectancy on average across the US. Of note, but not on this slide, if you stratify by race, life expectancy amongst Black individuals is lowest in the city of Boston at 77.6 actually, and highest among individuals who are identified as Asian at 86.3. And I'm sure if you disaggregated the Asian population, you would see differences, but that's how we do it, and it's 86.3. The lowest life expectancy by neighborhood is actually found in Mattapan. It's around 77 years of age. And life expectancy is highest, approximately 83 years, in Back Bay and the aggregate areas of downtown, Beacon Hill, North End, and West End. So looking at these data, and just scan the list, from an overall city level, from a neighborhood perspective, things really aren't so bad. And if we stopped here, we would say, well, we don't have that much to do, really. There's certainly differences, but the differences just aren't that egregious. So what happens when you stop at this level of analysis is that you miss pockets of relative disadvantage and actually pockets of deprivation is what we call it in public health. You need to zoom in to smaller geographic areas, census tracts within these larger neighborhoods. So let's do that. Let's return to Back Bay and look at census tracts. And as was the case 15 to 20 years ago, there is a census tract in Back Bay with one of the highest life expectancies in Boston, and that's 92 years of age from birth. So let's go to Roxbury. When we similarly zoom into Roxbury, we find that there's a census tract with the lowest life expectancy in Boston, and it's a little less than 69 years of age. So again, these areas might be 2 miles away from each other, but they're worlds apart. If you compare the demographics in each area, in Roxbury, median income is more than 70% less than in Back Bay. Only 44% of individuals have college degrees versus 91% in Back Bay. Roxbury is also about 50% Black and about 32% Latinx, whereas Back Bay is largely a white neighborhood with a small percentage of Latinx individuals and only 1% Black. So life expectancy difference between one of the census tracts with the highest life expectancy in Boston and the census tract with the lowest is about 23 years. Now, at this point, you might be asking, well, Dr. Ojikutu, the life expectancy gap, as you just stated, was 33 years and now it's 23. So that's progress, right? So as I said, some progress may have been made, but there have also been significant demographic shifts in Roxbury as a whole. Gentrification has occurred, and it's likely to account for some of these differences. And secondly, this isn't just about Roxbury and these data, though this is what is in the media right now. There are also areas of low life expectancy in other parts of our city. So we're looking at this further and we'll produce a final report in 2024. But I think there's clearly a problem here that we should acknowledge and really be struck by. So what about the impact of COVID-19 on life expectancy here in Boston? Well, a comparison of life expectancy in Boston the 2 years before the COVID-19 pandemic, so that's 2018 and 2019, and the first 2 years of a COVID-19 pandemic, so 2020 and 2021, demonstrates that we lost overall as a city about 2.4 years of life expectancy. That's striking, but it's similar to what happened across the US. Even more concerning is the fact that people of color suffered significantly more years of life loss than white individuals. So you look at these data, Latinx residents lost approximately 4 years, followed by Black residents at 3.3 years, and Asian residents around 3 years. And white residents had the smallest decrease in life expectancy at 1.1 years. It remains to be seen whether or not those years of life expectancy that have been lost will actually be regained. I think it's very helpful as you look at life expectancy to really think about premature mortality. So that is death that occurs before expected or before the average age of death within a population. And in our data, we define premature mortality as death prior to the age of 65. And so obviously you want that number to be low or to trend downward. And from 2017 to 2021, there was no significant change in the rate of premature mortality among Asian, Latinx, or white residents in Boston. But look at the gray line. That line represents Black individuals. And from 2017 to 2021, Black residents experienced a 37% increase in premature mortality. Of note, premature mortality in Boston is notably highest in Dorchester, Roxbury, and Mattapan. Not surprisingly, but it's important for us to think about neighborhood level as well as demographic differences. So why is that the case? I think that would be the next natural question. Well, here are the #1 causes of premature mortality among Black Boston residents over time. So cancer was the leading cause of premature mortality for Black Boston residents in 2017 and 2018. That was replaced by heart disease in 2019, and then by something called accidents in 2020 and 2021. So what are accidents? Accidents are deaths due to unintentional injury and include deaths due to drug overdose. In fact, the majority of the accidents noted here among Black residents are actually due to drug overdose. And we know from a report that the state released earlier this year that from 2019 to 2022, Boston experienced about a 36% increase in opioid-related deaths, more than twice the statewide rate of increase over that same time period. And if you look at just Black individuals, we've essentially noted an increase of about 30% in opioid-related mortality within the Black population. So in a couple weeks, the Boston Public Health Commission is going to be releasing a new report that focuses beyond opioid use, but really looking at all substance use disorders. And it will delve more deeply into substance use in our city and look at treatment utilization, treatment access. And I think it's an important report for you to take a look at. What it tells us is a very sobering story about where things are going. So, in addition to life expectancy, infant mortality is another commonly used factor to assess and rank health and wellness and health equity of a community or a geographic region. So, low birth weight, which you see in this graph, is defined by the birth of babies weighing less than 5.5 pounds, is a strong predictor of infant mortality. Significant racial disparities have existed for decades in terms of low birth rate here in Boston. Here you see differences from 2010 all the way up to 2021. And most recently, the rate of low birth weight infants is 2.2 times higher among Black Boston residents versus white. So what does this mean in terms of infant mortality? Well, there's low birth weight, but then there's also premature birth. And both of those things are important predictors to take a look at. So here we look at infant mortality itself. And most recently, the infant mortality rate amongst Black infants in Boston was 9.7 deaths per 1,000 live births. And that is 3 times higher than the rate for white infants at 3.2 deaths per 1,000 births. That difference is 6.5 deaths per 1,000 births. Now keep that in mind because I'm going to show you something in a slide next that is rather concerning. And again, as you see in this graph, these differences have been long-standing. So here's what I wanted to show you. If we trace infant mortality differences back, much further, decades further back, what you see, as I said, is quite concerning. So this is a New England Journal of Medicine study published in 1985 that examined race and income patterns of mortality from birth through adolescence here in Boston. And the authors reviewed data from 1972 to 1979. And they found that the difference in infant mortality between Black and white residents here in Boston during that time period in the 70s was approximately 6.9 deaths per 1,000 births. Now, I just showed you in 2021, the most recent data we have available, the difference in infant mortality between Black and white residents was 6.5. So 6.9 versus 6.5. And these data are from 50 years ago. So certainly we know that overall infant mortality has declined, but there's a problem when we continue to see these persistent and pervasive disparities. So let's turn to strategies that have been implemented because there's been a lot of work that's done. I think that the point of this is to highlight that there's been work that's been done, but maybe it's not always enough or not always the right kind of work that's been done. So many local organizations, hospitals, community health centers have leveraged resources and developed innovative programming here in our city to address racial health and equity. And as I said, some progress has been made, but again, not enough. I'll use the Boston Public Health Commission, our local health department, to demonstrate the robust programming that has been implemented to address health and equity. We are the oldest health department in the country. There's always been a focus on racial health equity and social justice, at least in the recent decades within our health department, and we lead more than 60 programs to address these issues. And I'm proud to share that our new mission statement actually highlights our commitment to working in partnership with communities and promoting the health of those most impacted by racism and systemic inequities. I mentioned this while I'm saying that, these words are just buzzwords, they're just words, but I do think that calling out racism and inequity in our mission statement, which is something that isn't common within public health departments, it may seem like a small and insignificant step. Quite honestly, it is important because we've tried to back up our words with really intentional actions to address these issues. So for us, I do think that it's important for us to highlight what the work that we're doing and the intentionality in our efforts. Okay, so here are a few examples of some of the work that we're doing. So to address maternal morbidity, maternal mortality, and infant mortality, the Boston Public Health Commission established Healthy Baby, Healthy Child. It's actually probably the longest standing program at the Boston Public Health Commission. It's, we just had the 33-year anniversary recently. It is a home visiting program for pregnant and parenting families with a child under 5. And a vast majority, if not all of the families, the birthing individuals are low income and Black or Latinx. So this program is staffed by nurses, community health workers. We recently hired a medical director to really trying to strengthen the efforts and what's going on in terms of these home visits and the case management that occurs. It's a great program, provides health and prenatal education, breastfeeding, counseling, and short-term mental health counseling. So robust, holistic, comprehensive programming that's offered in many languages. I would also just want to call out that Becky Cruz Crossan, Morgan Taylor McFadden, and the Bureau Director, Dr. Uchenna and Ndulue, are really leading this effort, and they've really put forth an enormous effort to, make this program strong and make it last for this many years. We also address social determinants of health. And one of the programs that we work on is in collaboration with the Boston Housing Authority. And that's Healthy Start in Housing. It essentially offers housing to pregnant individuals or individuals with a family with a child up to the age of 2 who meet certain eligibility criteria, have a history of housing instability and underlying medical conditions. And it's an important partnership. I think it does good work. And again, it really does try to tackle at least one of the social determinants of health that's quite important. And this, again, is in partnership with other city entities, but certainly something that we are trying to expand. But it's important to note that as a program, it's time limited in terms of who actually participates, and it's just limited in its capacity, which I think is important to acknowledge. And then just turning to chronic disease programming very briefly, we've had lots of programs over the years, and many of my colleagues at all the health departments across the country have had a lot of chronic disease programming. Unfortunately, with COVID-19, a lot of our funding has been, moved into infectious diseases, infectious disease control, but still, we've been able to maintain efforts to train community health workers, to do nutrition education, providing funding to the community health centers, to support a lot of activities in terms of chronic diseases. We have a very strong asthma prevention initiative. Just a lot of really, really, I think, important important programs. But these are the type of programs that are offered by the Boston Public Health Commission, also offered, like I said, by lots of other organizations and in partnership. So lots of people, lots of great work. Why haven't we closed this gap? Why haven't we eliminated disparities? Well, it's complicated. So I'm going to pose 10 reasons, and I'm happy to discuss. I'm sure lots of people have their own thoughts, but I do think it's important for us to recognize why we are at this current place and why we haven't been able to truly address the persistent and pervasive inequities that we've noted. So, they're not in any order, but I do think that some of these are probably more impactful than others. So, number one, we have a tendency, and a lot of our funding goes into individual household level interventions. We see an impact. They're clinically connected. And I think that's one of the, strategies that we tend to jump at in terms of trying to address inequities. And certainly that is similar to it's the underlying premise of the home visits that I mentioned. Programs are more often than not clinically oriented, they're disease focused, and they're aligned with hospitals and clinics. And that's okay. There should be some element of programs that are clinically oriented and again, are individual level, but you need something more. Programs are time limited. As I mentioned, even our, Healthy Start in Housing program, there's a limited period of time when people, can participate, and it may not be enough for many people. And I think that the reason for that is because, programs are not brought to scale. There isn't a significant financial investment. It's not large enough to actually meet this enormous need that we've acknowledged exists. Our efforts are institutionally siloed. I mean, those of you who know Boston well know that, we have lots of wonderful institutions. We are resource rich, but we don't necessarily collaborate. We move things forward on our own, and oftentimes that isn't the way to go. We really do need to partner, and I'll show you some efforts that I think are important as we move forward. Quite honestly, there's lack of community ownership. No matter how many community advisory boards we have, no matter how many times we engage, survey, have focus groups, have listening sessions, that doesn't mean that the community is truly owning an intervention. And I think that the key here is that sharing power, sharing resources, shifting power into the hands of community members, that's hard. And that's one of the areas that I think is really kind of stopping us from getting to where we need to go. There's also lack of political will. We're lucky right now here in Boston. We have a very progressive mayor who's very interested in these issues. But certainly, if you're talking about trying to move the needle in regards to life expectancy, that may take decades. So an elected individual who's trying to get reelected may not have this as their primary, primary initiative that they want to move forward or that they want to invest in. There's also lack of societal interest. So we just talked about the fact that these terms, health equity, structural racism, racial justice, they're very popular right now. They're not always popular. And the popularity has actually declined from sort of the height of things in 2020 and 2021. I don't think there are many people who wouldn't agree that something is being lost over time. There are a lot of people, for those of you who know Boston, who would, drive straight down Mass Ave going north in the city and never necessarily turn into Roxbury. So like, you're saying you want health equity, but do we even know what that looks like? Do we even know what's going on in the communities where there are challenges? So that's a major concern. And then, quite frankly, altering policies and systems, that's hard work. That takes a lot. It's more than establishing a program. Even these robust programs that I mentioned, even all the work and the tireless efforts of folks, here and at the many community health centers and hospitals across our city. When you really want to create change, when you really want to get to the root of issues, you're doing a lot of extremely difficult work. And that's where I wonder if we're up to the challenge. I have to be honest. I think that is where the rubber sort of hits the road. And that's why things are difficult in terms of actually creating change. So let's talk about systems. What does that even really mean? And the issues of systemic inequity and structural racism. I think sometimes, again, we throw around these buzzwords and it's hard to really know exactly what we're talking about. So I'll try to sort of, narrow some of these sometimes academic definitions and make sense of it. So systemic health inequity. So that's the disadvantage of one group versus others through the unequal allocation of both power and resources, which manifests in disproportionate social, economic, and environmental conditions and results in poor health outcomes. So I sort of cut through the chase here, and I just said, look, this is really what we're talking about. We're talking about power. We're talking about resources. We're talking about the ability to make decisions about what happens in one's own community, what happens within a city where one lives. That is not distributed equally. And I think we all just have to admit that is the case, whether we be in Boston, whether we be in Chicago, wherever we are. So what is structural racism? Now, here's another buzzword that is oftentimes defined very verbosely, if you will. And I think, again, if you really drill down to what we're talking about systems of hierarchy, privilege, and power that exclude non-white individuals. An important piece of this, really the fundamental piece of this, is who has the material resources and who has the power to control those material resources. And more often than not, it is not the individuals who have the lived experience and who disproportionately suffer from poor outcomes. That's structural racism. So then, what do we do about all this? What might move the needle? Well, I don't believe that change is going to occur without multi-level strategies that are harder to implement. Multi-level strategies that involve structural interventions, which alter the political, social, and economic environments that create the social determinants of health, that really determine whether you have high quality social determinants of health and you have the right quantity of social determinants of health in terms of your housing, your income, your built environment, all of them. Until we do that and combine those with some of the individual level, household level, clinical oriented efforts, until we do that in a robust and cohesive way, we're just not going to get anywhere. And they need to be place-based, they need to be community-led, and I'm going to keep emphasizing that they do need to be community-led, and they need to be sustainable over time. So one strategy that's being pursued here in Boston is a group that I am, involved in, the Health Equity Compact. And it's a group of 80 leaders in Massachusetts who are committed to sustainable change to advancing health equity. Most of the leaders are people of color. I think we're at a very unique, really extraordinary time across Massachusetts where you have so many people of color who are leading large organizations, large either health-related or public health-related organizations. So a key strategy for the Health Equity Compact is passing an act to advance health equity. And that essentially will make government more equitable, by creating an executive office of equity and creating other positions within state government, hold our systems accountable through data collection, data sharing, which is oftentimes challenging. And from a public health perspective, and what I'm personally really interested in as a public health leader, is that it will hopefully create health equity zones. Okay, so what are health equity zones? So health equity zones are really an innovative place-based population level strategy that funds local efforts that have been identified by communities, by that community who's actually living there. The purpose of which is to advance health equity in such a way that hasn't necessarily been done before, because it is people who are engaged in the health equity zones, leaders in the health equity zones, communities who are engaged there, they have ownership of the interventions that are being implemented. And that is such a key piece. It really does shift decision-making power from institutions where power usually lies into communities, supports community-led coalitions to advance health equity, and hopefully it will actually fund and put the money where it needs to be placed in people's communities so that strategies can be invested in and address local needs. And then hopefully it also promotes accountability and sustainability over time. Now, Rhode Island has implemented health equity zones and it has had some positive impact. So when I say there are things that we haven't done yet, this is something we haven't really robustly attempted this yet. And hopefully with this act to advance health equity, we will get there or come to some semblance of getting there. In order to get there, though, I think you have to have the right people at the table and you have to have the right investment. And I think that's a key piece of what we're trying to do within the Boston Community Health Collaborative, which is formally known as the CHNOT. So this is essentially a group of lots of different folks from different sectors, primarily, health centers. The Boston Public Health Commission leads the administrative access, the administrative component of this. Certainly hospitals are at the table, community-based organizations, stakeholders, community residents, all at the table with the purpose of identifying community needs and actually thinking about ways to address them. So that's a laudable goal. I think it's a wonderful way to bring people together, and I think there's some great documents online. Let me show you what has been identified by community, because it's not surprising, and it's what we've seen in previous efforts to understand community needs. People want economic mobility and inclusion. People want access to resources. That is what it is. People want the ability to have enough money to live their life, to also save, to think about houses and getting a mortgage in a very expensive city. Certainly housing is a key piece of this. Not just, any housing, because Boston has an older housing stock. So you want quality housing, you want safe housing, you want stable housing, and you want it to be affordable. Certainly people want access to services overall. We have lots of services in Boston. Oftentimes they're not coordinated. People don't even know that they exist. People want access to services. And certainly mental and behavioral health have risen to the forefront as major concerns, not that they are new, but just major concerns during COVID, post-COVID, and these are needs that, that the community really want to be addressed. But I think that the key here, and I think the key message in the work that's being done here, is that what's happening is that entities are investing independently in some of these things. We have, like I said, we have large hospitals. We have a lot of people who are doing wonderful things. They're doing wonderful things in silos. And maybe at some point people, sort of thought that worked, but it's time to try something different. Imagine what might be accomplished if all of the entities that I just mentioned invested together deeply in one outcome, like increasing life expectancy in Boston across the board for everybody. Imagine how powerful that would be. So when we talk about what we haven't done that yet. Okay, here's also something that we haven't done yet, but other people are trying to do, and I think it's important for us to think about. We know that wealth is one of the most important drivers of health outcomes, and wealth is unequally distributed across the U.S. There's nothing novel in that statement. I think everybody knows that that's the case. How do you get there? Well, you invest in economic mobility pathways for people. You got to start somewhere. And so there are a number of ways to do that. So there are a number of, guaranteed income pilots across the country, most notably, I think close to us in Cambridge. I know Worcester Worcester is going to start maybe a universal income pilot where you're giving people sort of a monthly allocation, a monthly amount of money, and they use that as they will. You're not telling them what to do with it. That is part of the process, is that you're giving them something so they have less concerns, less worries. They can direct their attention to the things that they need to direct it to improve health outcomes and to improve, their overall, wealth and excuse me, their well-being. But in addition to doing this, and in addition to monthly, payments, why not also have a package? Why not also have economic mobility strategies like increasing financial literacy, debt cancellation, mortgage subsidies, tax credits? People have talked about baby bonds. There are all sorts of things that we could be doing to more robustly get people on the path to economic mobility and potentially improve wealth and decrease the wealth gap here in this country. So again, this is something that we have not here in Boston done yet. So let's turn back to Black infant mortality. So as I said, this has just been a chronic issue, not just here in Boston, but across the country. And kind of just, we've been taking some time to think about what we could be doing differently, what we haven't done enough of. So we believe that the programs that have been implemented here in Boston have been outstanding. They're great programs. I think a lot of people talk about them. A lot of people have benefited, but we don't really have universal access to pre and postnatal, culturally and linguistically appropriate home visits. I mean, just across the board, everybody is getting access, particularly individuals birthing individuals who are Black getting access. Now, I think that it's important for us to, of course, work with DPH where there's a lot of work that's ongoing to ensure that there is, closer to universal access to these services. So again, it's scaling up the work that you do so that we're not just trying to impact a few, we're really trying to impact many. Economic mobility pathways for families. There's a strong evidence base that shows that improving economic mobility amongst young families improves child development and outcomes later on in life. We have funding now to expand doula access across all pregnant people and to actually think about how to scale it up such that everybody understands the utility and the evidence base behind doulas, which I think is incredibly important. We have a wonderful community action network, which is a group of community members who advise and provide guidance in regards to the work that we're doing, not just about infant mortality, but certainly maternal morbidity and mortality, enhancing that, shifting more power in their direction. I think that's the future. I think that's the key. And then just to speak about policies, there is an act relative to conducting fetal and infant mortality review that I think is important. It's on the table, and we're thinking very intensely about what we need to do. We actually don't have a fetal and infant mortality review in Boston, and that means reviewing all infant deaths in Boston, and there are approximately 120 deaths annually, and then developing policy and programmatic recommendations based on that fetal and infant mortality review. We need to know why infants are dying, and we don't have that data, even though this has been going on for such a long period of time. So we're hoping to move that forward, and we think that with these inputs, we can put forward a bold goal. We can say that we're going to lower Black infant mortality in Boston 20% in 5 years. Now, we need the financial inputs, and we're working on that. I tend to believe that where there's a will, there's a way, and we will get the money to get this done. But it is important for us to also set a goal. That's important. Okay, so I want to just turn to substance use disorder, and particularly some of the work that's being done in terms of our opioid remediation settlement, because I do think this is a good example of how with intentional effort, we can promote equity and ensure that you don't start a program and deepen inequity because you know that the inequity was right there. So then what do you do differently to make sure that it doesn't happen going forward? So I mentioned that we have these inequities in regards to substance use disorder and substance use mortality in Boston. And we do have an opportunity right now to address community identified concerns at this point. As many of you are aware, as part of the state settlement with companies that manufacture and distribute opioids, the city of Boston has received almost $5 million in funding and will continue to receive approximately $1 million per year over the next 15 years to reach a total of almost $22 million, and it may actually end up being more. So we recently completed a detailed process to capture community input regarding how these funds should be spent. The process took a little bit longer than we thought it was going to, because we wanted to make sure that we had diverse voices at the table. So sometimes all these processes, particularly when you talk about health equity zones and a lot of the work in regards to partnering with community and community leadership and community ownership, it does take longer. But at the end of the day, more than 400 residents of Boston, many with lived experience, participated in listening sessions and surveys, as well as local agencies who were able to participate. So what did they say? So what they said was they want housing. Now, remember, we saw that with the the Chennault CHIP, so the needs assessment that was previously done. So similarly, housing, equitable expansion of existing housing, low threshold housing. By low threshold, I mean without barriers, meaning that people don't have to be sober in order to access the housing. Permanent supportive housing, so housing for people who may still be struggling and need additional help. Prioritizing Black and Latinx populations, given the data that we have, prioritizing women who are oftentimes victims when they are unsheltered on the street. And certainly other ideas were also brought up. Key amongst them was equity grants to smaller community-based organizations who are doing the work, who are providing harm reduction, doing the work in terms of substance use disorder around our city. Overdose prevention centers. Certainly, I'm a proponent of overdose prevention centers. It's something we are looking at and trying to see if that's something that could be implemented. Certainly, New York City has done a wonderful job. And then supporting grieving families. We have a lot of families who have lost people and who need additional support. So what did we do from a policy standpoint here in Boston? And we did this prior to completing the surveys, because this is what we knew was, what the need was in terms of substance use disorder and unsheltered status. Well, we implemented a housing first policy. I mean, this is how we address substance use disorder and unsheltered status here in Boston. We believe that housing is healthcare. And that means immediate access to housing without conditions upon entry, meaning you don't have to be sober, you don't have to be in recovery. Access to harm reduction. We are a leader in harm reduction, access to mental health care as well as physical health care. This is important. So if you look forward at what it is that look back at what we have done and look forward in what we will do. What we've done is we have established a system where people who are unhoused and who are experiencing substance use disorder do have a place to go. And this has taken an enormous investment. We initially started this in January of 2022, and most recently we dismantled our encampment just a few weeks ago. Actually, I believe it was 2 weeks ago. And most of those individuals were placed in low threshold housing, and this was voluntary. So they have low threshold housing. The spaces have case management, they have nursing supports, they have harm reduction, and really kind of putting people on a trajectory to a better and safer existence. So what does this have to do with equity? So I told you that we know that we have these inequities in terms of substance use disorder, and particularly overdoses and deaths. But when you establish new programs, there has to be an intentional way that you're proceeding. You have to think about equity from the beginning. So we did that as we were establishing this particular housing strategy, and as we were thinking about the housing first policy. And what we found, and we were able to get a grant from the Office of Minority Health to look at this, is that there were no significant differences in the rate of placements noted by race, ethnicity, or gender. Across the board, there's been improved access to treatment and longer-term housing pathways amongst those individuals who were placed. And it's actually, I think, really been a way to show an example, I think, to other cities around the country. And we've talked to a lot of other cities about how you can do this. I think the one concern that we do have, and I think that anybody would have, is when you're thinking about sustainability, like how do we keep this going? And that then relates back to the opioid settlement funds. Using potentially some of that money to keep this work going, I think would be prudent. But certainly, as I said, those decisions haven't been made yet, and there are a lot of other things that that communities want. So just going back a little bit to this issue of communities and community empowerment, I think one of the other themes that I think is really, really important is thinking about how we can transfer money directly into communities. So this goes back to this idea of shifting power, not just sharing, but shifting money, shifting resources. So essentially what we did is we established a community health equity empowerment fund here in Boston. And what we tried to do, and what we will be doing soon, is shifting ARPA funding, federal funds to CBOs centered in census tracts with lower life expectancy and higher infant mortality. That's our goal. We're also doing this in conjunction with Mass General Brigham. We're in the process of selecting organizations for this, and hopefully in the next couple of weeks we will be able to announce that we are actually doing this. And we're actually hoping that what will happen is that these smaller community-based organizations will work together. We'll have strong coalitions. They'll have the infrastructure to actually stay afloat, because we know that that's one of the problems that's also occurred, is that during COVID-19, lots of things got going, lots of people were funded to do things, and then they just don't have the resources to continue. So this is an important initiative that we are moving forward. And again, we should be able to announce the results of this very soon. So we know community mobilization, community empowerment, that's how change occurs. And again, we saw this during COVID-19. We need to use those lessons learned to do more than just talk about equity, more than talk about racial justice, more than talk about anti-racism. We need to actually create change. And I think we know how to do it. So what I'll end with is a call to action. I've talked about a lot of things here. I think all of them are things that we know, but it's good to uplift them. And I think the other piece is that even though we know them, this work is hard if we really want to achieve the goals that we say we want to achieve. We need to build community power by shifting resources into communities. It's not just about sharing, it really is about shifting. We need to set big goals locally. There are national targets, but like I said, decreasing infant mortality 20% in 5 years, that's a big goal locally. Determining how many additional years of life expectancy we should all experience here in Boston. That's a big local goal. We need to set these big visionary local goals. Changing long-standing systems, policies, structures, that takes time. It's hard, but I think we're on the road to doing that. Investing collaboratively, actually picking something. If it's life expectancy, let's invest deep. Let's invest together. That's how we get desired outcomes, not working in silos. That's been done. We know that that doesn't work. And then I didn't talk about this as much, but I just want to say inviting new leadership, new voices, new partnerships. That's important. There are non-traditional partners out there who are also interested in this work. So the question for me is, are we ready? And I said I was going to, and hopefully I'll tell you that if you'd asked me this question probably 5 years ago, I would have said, I'm really not sure, probably not. But I have to say, in thinking about this, as I was putting this presentation and many of the other things that I've been doing recently, the answer is yes, we're more than ready. We're more than ready locally. I think we're more than ready. I think we have the right inputs across the state with wonderful leadership at many different levels. So I do think that we can move forward. We just need to take the right intentional steps. So I just want to end by thanking the Boston Public Health Commission. It takes a village to put a presentation together, So all of these entities were extremely instrumental in helping me pull these thoughts together. And I just want to acknowledge their contribution. And certainly, I probably went a little bit over time, but I'm here to answer questions. And certainly I'm available via email, and you can always reach out with your thoughts about what I just presented. Thank you.
Dr. Ojikutu, thank you. It was so chock full of both information and strategies that there's a lot that will be sinking in for me, at least, and I think for some of our audience members over time. I also really appreciate your hopeful message at the end. I actually would like to ask the audience if you agree with Dr. Ojikutu that we are ready, that we can take some of those incredibly difficult but also necessary steps that were there on your last slide. And I think we have time. So I'd like people to answer that question in the chat. I'd like to know if people out there feel ready for this. MPHA feels ready for this, and we want to be part of the movement that makes part of those changes. But as you pointed out, that takes building power and building community voice and a willingness not to share power, but to shift it. And so it's going to take a lot of us working together. We have time, I think, for one quick question here, and then we will try to answer some of the other questions through email responses. But Anne McHugh asked a really, I think, really important question in the Q&A, which is how public health folks and our partners can get more involved in the income equality work that you talked about, and whether you see any pathways for that. So that's one thing I'm also really interested in.
So I think that absolutely there's room for everybody at the table. So one of the ways that we can all work together is through our CHIP, our Boston Community Health Collaborative, as we're calling it now. I think there are many folks at the table there, and certainly residents of Boston. And used to work at the Boston Public Health Commission. I know her work extremely well. And I think any of you all who are residents of Boston who are interested should just reach out. I can, leave my slides with Carlene. There's actually a website that you can go to and email addresses. Just reach out and say, hey, I would like to contribute in some way. I have this thought, I have this idea. Again, there isn't one solution here, and there are great thoughts that I've noticed, from many audiences as I've talked about these issues.
I think that's a really important point that came out throughout your presentation, that there is not one strategy, but there are multiple strategies that build on each other and are going to create that that increasing equity. So I really do appreciate that. I have one other question. We have 2 minutes, which is about in pointing to the health equity compact work in the health equity zones, as well as to the transformed Boston CHIP process that you talked about. I wonder, given that the social determinants of health sit outside of public health infrastructure, they're in transportation and housing and labor, how are you at the Boston Public Health Commission bringing in other municipal partners that have responsibility for those sectors as you move forward in this work?
So that's a really important point. And I think it's been a challenge, not just for us here in Boston, but as I talk to my colleagues, it is about all these other pieces to the puzzle, and we may not be speaking the same language, So it's an important point. A lot of these citywide agencies are actually part of the transformed CHIP, that they're actually, at the table as we're discussing economic mobility. A lot of that work is being done by cabinet leads in Mayor Wu's cabinet. We're talking about housing. Certainly that's done by the Mayor's Office of Housing with our, we work in collaboration, but they're working on that. There are folks who are experts who are working on it. I think it is about talking. It is about having a leader, in this case, a mayor who is interested in having these discussions. And we're working on a lot of these things across the board. So it's not just a myopic focus on what we're doing here in public health. It really is, how do you get to transformative change? That involves lots of different people in multiple sectors and non-traditional partners, I would also say.
Well, yeah, I could ask you another 25 questions, and I know people in the audience could too. But I need to thank you and ask the audience to help me thank you one more time for that vision, that hope, that putting out there that this is not just hard and complicated, but it involves power and shifting power and privilege, and that there are those who are going to resist that. And so we really do have work to do for that kind of community building and power shifting. And I just so appreciate those points, because I think you were hopeful today. And so I'm really grateful for that. Thank you so much.